I'm going to tell you a little story about how we got to the point of doing a collaborative population-based versus practice-based reminder recall intervention to test these two methods for increasing immunization rates in young children. So first of all, efficacy, effectiveness. Immunizations are basically second only to clean water in terms of the number of deaths and morbidity they've prevented. And this slide just makes that point. If you look over on the right, this is the percent decrease in these common childhood diseases since after the advent of vaccines. So the Healthy People 2020 goal is to increase the proportion of children 19 to 35 months who receive all routine recommended vaccine, and their target is 80%. It's kind of hard to believe we're not there given the incredible efficacy of vaccines, right? Where we are is in the United States about 73% overall. In Colorado, we were 68%. So definitely some room to go. So why is this? I'm not going to go through all these barriers that have been recognized not only through our research but through many researchers. Just to make the point that if you were going to think about how were you going to better implement immunization delivery, you'd have a lot of issues to deal with. So you could focus on any of these areas. And, you know, some of them are very tough to tackle. Some of them are more straightforward. We chose, because a lot of these issues actually affect small numbers, not huge numbers, we chose to take a very pragmatic approach and try to reach the most number of children we could and not specialize too much. So we took a highly pragmatic approach. So what's been shown to work before in immunization delivery based on strong evidence is reminder recall. And this is recommended, probably the strongest recommendation from the Community Preventive Services Task Force. So reminder is notification to inform patients or parents that their child is due for a vaccine, and recall is reminding them when they're already overdue. And it can be delivered in a whole lot of different ways: mail, phone, autodialer, text, email, etc. But in the past, it's been conducted at the level of practices, using usually practice-based systems. And there have been, just in terms of the evidence, this is going to take a sharp turn here, so I want to make sure you get this. There have been 47 RCTs that have been included in Cochrane review that show effectiveness of reminder recall. However, when we reviewed lots of these, and we did a number of these trials that are part of this, when we reviewed these, 35 out of 47 were actually done by research teams coming into practices, and none of these trials measured sustainability. So lots of effectiveness in the real world, but not necessarily so real world. So our study team had already spent years studying and trying to improve practice-based reminder recall efforts. We had measured effectiveness in different settings, in different populations. We've done a lot of qualitative work to look at the barriers. And basically, what did we learn? It's really tough to implement reminder recall, even in highly motivated practices that have access to a centralized immunization information system, what's more commonly known as a immunization registry. And there's lots of barriers to implementation. And I think the top three that we felt were almost universally there were competing demands. Primary care practitioners are so busy they can't add two more keystrokes, as you said, not two more keystrokes. There were inadequate systems to deliver the intervention and usually inadequate training. So you might get somebody trained up and then they left the practice. And then there were cost considerations. At the same time, this is actually a typo, national data suggests that 16% of physicians were doing reminder recall nationally. So after many years of work, we decided to learn from implementation failure. And we thought it was time for a new idea that accomplished what practices wanted for their patients, but facilitated implementation and sustainability. So what did providers want? And they wanted lots of things, and patients wanted lots of things. I'm just going to bring this down to a couple of very actionable items. We did a lot of surveys and qualitative interviews. Providers wanted to do reminder recall for their patients, but the majority thought they just couldn't. It was not feasible. So there was a mixed feeling there. The vast majority, 85%, were okay with public health taking a major role in this. Only 15% were not okay with that. What did parents want? Roughly half preferred for their provider to do reminder recall, and half didn't care if the reminder recall came from the public health department or even preferred the public health department. However, very few parents were, again, adamantly resistant. So this was our implementation idea, a centralized and collaborative approach. We would make use of the state IIS to simplify and centralize reminder recall. So the algorithms that the IIS has would determine who was not up to date. The IIS can generate mailing addresses or lists or even postcards. The state public health department would conduct the reminder recall centrally. They would push the button. This would reduce the burden on practices, and it would potentially reach children who are not in a practice and therefore would not get practice-based reminder recall. And in order to be responsive to the provider and parent desires, the reminder recall messages could come from both the practice and the public health department, so that there would be that endorsement of the practice. In addition, the practices could actively collaborate with the public health department by updating addresses and therefore decreasing costs. So that was our plan. And in development of this collaborative intervention, we did surveys and qualitative data. As I said, we also had advisory committees of parents and providers who helped us look at the qualitative data and survey data and make some decisions. So I just want to highlight the principles that we used in developing this approach. First of all, we designed the intervention with sustainability in mind. And I guess you could say designing for dissemination as well. Same thing. We wanted it to be low burden. We wanted it to capitalize on existing technologies and systems so that it would be easy to disseminate widely. We wanted to design it for scalability. So this kind of system, if it worked, could be used in another state. It could be used across the state. So very scalable. And the intervention was guided by the preferences of providers and patients, not everybody, but the majority. We did, as I said, try to get the endorsement of the trusted professional, and the letters or reminder recall messages did have some information about immunization, so there was some knowledge transfer involved there. And we had a lot of collaboration between stakeholders to increase the efficiency and decrease the costs. The other thing we did was iterative testing with the stakeholders. Midway, at the end, several times. So we did make some mid-course corrections. The goals were highly pragmatic. We were trying to increase rates for entire populations of children with the highest level of efficiency, lowest cost, and without undermining the concept of the medical home. And this required a highly collaborative approach involving our main partner was the state public health department, but also the local public health departments. And in order to capture that, we involved the Association of Local Public Health Organizations, or CALFO. The local public health departments, we attended a statewide meeting, presented this to them. We got a lot of feedback. We did key informant interviews. Not everybody was happy, but the majority were. We involved the Children's Immunization Coalition and local primary care organizations. And we had, as I said, the Parent Advisory Committee was selected with the help of providers. So in evaluating this, we chose a very pragmatic approach. The population included all children in identified counties. So that kind of heterogeneous population is consistent with a pragmatic trial rather than a classic clinical trial. The settings, again, were very heterogeneous, all urban and rural counties and all primary care providers. In terms of the evaluation, I'm not going to go through this, thank goodness Russ did, but this is the REAIM evaluation framework that we did. And I just want to highlight, the important, I'm going to show you a few results, and I want to highlight the importance of reach in this study, the concept of reach. If we had not measured reach, we would not have understood what this study did. So these were our objectives: to directly compare a collaborative population-based approach with a practice-based approach, and I won't go into the methods we used in the practice-based, but suffice it to say it was very pragmatic, what you might do for entire counties in terms of encouraging them. So here's the reach. In the practice-based counties, because 10 practices did reminder recall out of 195, the greatest potential reach of that intervention was 5%. Whereas in the population-based, and this was an accurate reach because we knew exactly, we corrected addresses, etc., the reach was 85%. So that's the answer in this trial, is the reach. It's very important, obviously, that we looked at that. So this is I'm only going to show you two results. This is the percent receiving any vaccine within 6 months. On the left of the population-based, 32% versus 23% in the practice-based, with an absolute effect difference of 9%. Excuse me, I thought I got rid of these slides. Okay, wait. Cost. Per child brought up to date, $17 in the population-based. Per child, who received one vaccine, $10 versus $38. You know, this is not my latest slides, but we'll get there. Okay, so lessons learned. I think the biggest lessons were to design implementation interventions with sustainability or dissemination in mind from the get-go, and to use a poker analogy: know when to hold them, know when to fold them, know when to rethink the plan. Sometimes you got to start over and say, this is not working, I want to do something else. And thirdly, listen to stakeholders and recipients of the intervention and continue to adjust iteratively. Thanks.
Any clarifying questions? Okay. Then we'll go on to our last speaker, Spiro Manson. Oh, I'm sorry.
I was actually just trying to understand one aspect of it.
Yeah.
Were there counties? I thought the state was all of the states. So was it everybody got the statewide reminders and then additional practices? So there were control counties? Okay.
So there were 16 counties, 8 of them got population-based, 8 of them got
Thanks.
practice-based. All right.
Great. Good morning. In Indian country, if you don't reply, it's offensive. Thank you. We've been working on the cultural competence of our dean in public health, and it's taken. So. I'm here this morning to share with you our lessons learned and the outcomes thereof with respect to the special diabetes program for Indians. And it has two major arms. One is the reduction of CVD risk, which is the greatest complication for diabetes among Indian and Native people. And the second arm, the one that focused this morning, has to do with preventing onset of diabetes among those who are pre-diabetic, exactly as David indicated. And please, I'll ask you to remember everything he said, because in parallel, it's highly informative. Let's see, which is... Okay, how's it go forward? There we go. Let me just a little bit of background. First off, is that among American Indian and Alaska Natives in the United States, among the highest prevalence of diabetes as well as incidence. It's just 17% today. That is nearly double that, in fact more than double that among their white non-Hispanic counterparts in the United States. I mentioned that cardiovascular disease is the most serious complication of that. In the context of this particular effort, we conducted a cost of care study in which it would determine that 11% of American Indian patients served by the largest medical facility in the Indian Health Service who are diabetic, and they consumed nearly 37% of the total healthcare expenditures in that particular facility. In terms of developing partnerships, recognizing the epidemic proportion of diabetes in Indian and Native communities, the U.S. Congress, through the efforts of a number of important Native advocacy groups, in 1997, as a part of the Balanced Budget Act, initiated the funding of the Special Diabetes Program for Indians. It began in about $50 million in that first year, and ultimately by 2002 was $100 million a year. And it was focusing on getting out to as many as possible of the 550 tribal communities across the country, federally recognized tribes specifically, to accomplish several things. It was one, to move the readiness of these communities to recognizing that diabetes is a problem. Secondly, beginning to mobilize key stakeholders in those communities and elevate that recognition of a problem to systematic discourse in the community about the nature of those concerns and the things that may be done, and to begin to till the soil and introduce some of the community-wide activities that might be undertaken with respect to preventing diabetes more broadly. Hence, things like Just Move It and other kinds of programs found root in that work in the early part of the 1990s. I'll get this sooner or later. Congress was very pleased with the progress in that particular effort. There, in fact, was enormous evidence that Indian and Native communities had moved forward in terms of recognizing the problem, beginning to mobilize themselves around it, galvanizing key stakeholders, and beginning to attempt to address this issue, albeit in relatively rudimentary ways, given the lack of knowledge and information about how we might pursue evidence-based practices at that point in time. Fortunately, as David noted, the NIDDK-sponsored diabetes prevention program, the efficacy trial that had two arms to it, notably the lifestyle balance curriculum, which focused, it had some very specific goals with respect to weight loss and exercise increase and change in dietary patterns, had been completed. In fact, was completed early because of its early demonstration of success. Congress mandated that they would continue to fund this broader initiative in Indian and Native communities at $125 million a year approximately. And they said, but we want now to have these communities move forward into a more evidence-based approach that we can get a better handle on what our return on investment would be and can be if we move forward to institutionalize such efforts based upon evidence available at that point in time. So in the 2002 reauthorization, they funded something called the SDPI demonstration projects. Again, two arms to them. I'll only be talking about the diabetes prevention arm today. And you can see here the key elements of it that I'll come back to in a moment. The timeline for this was then we became responsible here at the University of Colorado for orchestrating both all of the program development side as well as the formal evaluation. It began in 2003 when we crafted a request for applications that went out across Indian and Native communities nationwide, soliciting proposals to engage and undertake the implementation and evaluation and ultimately the institutionalization of the original NIDDK lifestyle balance curriculum. We were able to do that in consultation with many of the tribal communities that we've been working with in the previous 5 years with that groundwork had begun, with the Indian Health Service. We crafted the application itself based upon that input. We involved a number of different key stakeholders from across the country in that regard. We actually held the review right here in this room. There were 130 applications to each of the different arms from across Indian country. One of the interesting things is that Indian and Native communities, the notion of competing against one another is absolutely a culturally sacrosanct thing not to violate. So we had a major challenge in figuring out how to frame this particular effort so as to move past that early anticipated barrier, and we were successful in doing so. Then we moved into a full 14-month planning year. Talk briefly about that. That shifted then into implementation for over 2005 to 2010. 2010, program was demonstrated successful. We went into institutionalization, and now we're about to embark on dissemination to the hundreds of other tribal communities that did not have an opportunity to participate in it. Just to give you a sense with respect to the outcome of the request for applications, there were 36, all represented by red flags here in pins. Grantees awarded across the country. Since many of them were in consortium arrangements, there are 94 4 different tribal communities across the country that were funded and have been funded to date in this undertaking. In terms of agenda setting, the agenda was already set for us in large part because Congress mandated that we embrace and move forward with an evidence-based practice, specifically that NIDDK DPP lifestyle balance intervention, which had these particular features to it. The question was, of course, though it was proven effective in very specific segments of our community, would it be so in Indian and Native communities? Now, as a parenthetical note, in the original efficacy study, there were 3 tribal communities that participated, that 161 participants out of a little over 3,000 participants. So we had an opportunity to, an early indication of some of the lessons learned from that, but the outcome data were basically so small that we couldn't learn much from that. So just to note, David anticipated a little bit, the DPP, our goal was to screen Indian and Native people who were pre-diabetic, as David noted, to recruit and enroll eligible participants, to engage them in the 16-session DPP lifestyle balance curriculum, to complement that with individual lifestyle coaching sessions and physical activity programs, build a retention and aftercore that would keep them engaged post-prevention, and to continue to enrich and enhance and support the community activities that were intended to support the gains through the actual intervention. It was really stunning to see the level of creativity and innovation that all of these communities brought to bear. In developing the intervention, this planning year, this 14-month period, was absolutely critical. What we did was we brought together 6 times for 2.5 days, 3 to 5 representatives from each of the 36 grantee programs, again, here in this room, to actually work through systematically a whole series of questions that have been anticipated by this discussion in terms of thinking about this particular intervention, the lifestyle balance curriculum, that was laid out in a particular format, content, delivery structure with the particular goals and objectives that are characteristic of it. But how do we make it their own? How do we actually, as David noted, you move from the one-on-one format to the group format. Well, what does that tend to do in terms of issues of fidelity for implementation? How can we think about capitalizing on some of the strengths in the Indian communities in which many of us are family-oriented? So we opened up the curriculum and the participation to key family members to participate. Imagine, if you will, what mom, who might be a participant in this program, was being taught how to eat and cook differently, and the reception she would get at home if her family hadn't been involved in that curriculum about her cooking for not only herself but everybody else in the family. And we're trying to anticipate those kinds of potential barriers. So we had numerous panels of the grantee staff involved over these many meetings to address issues of content, format, delivery, and duration. We settled on the notion of flexible uniformity. How do we achieve locally meaningful fidelity in terms of the translation of the key elements of this intervention into local application? The grantees were full participants in the evaluation design, which is really interesting because as a scientist, I had a particular mindset about some of the absolutely essential features. They went well beyond them. We ended up with a multi-level design, including not only the individual participants, the family members, the providers, the programs, and the community. It was really remarkable. And this particular year also underscored for us the importance of building capacity at the staff level because we anticipated and experienced a 30% turnover rate each year. And so how do you think about continuing to provide for the capacity that will carry beyond any one individual? What were the lessons learned? The lessons learned were really, I think, pretty straightforward for us. Everything has to be understood and rendered meaningful, rendered meaningful in local terms. Peer-to-peer learning is absolutely critical. David's point about not seeing a single patient or participant was absolutely true here. The only time in which I, for example, became personally involved in this is in January of 2007 when we bring all the grantees together. I made a public commitment to lose 110 pounds so that I walked the talk, and I did, following the same design. And I can't tell you how powerful that was, both in terms of the intervention on me, as well as being able to demonstrate that those of us who were leading it could in fact adhere to the basic principles that we were espousing. Peer-to-peer learning is really critical. You get talking heads up there, the experts. One woman said, what we don't need are more Indian experts. What we really need are more expert Indians. And so that's that notion, and there is this expertise at the local level. So the challenge is figuring out how to identify that expertise, how to identify local champions, how to support and promote them so that they become the ones that are actually transmitting the interventions itself. Compromise and negotiation are as much art as science. And lastly, success only precedes work in the dictionary. And there's absolutely no doubt that this was the hardest work I've ever done in my entire professional life. But it was really, the challenge was how to bring forward indigenous gardens into the development of the cooking and the classes and the meal planning. How to bring forward, for example, classic traditional cultural activities such as canoeing and other kinds of things into improving the physical activity and engagement of the youth. How to use, for example, intergenerational activities, whether it be gardening or beadwork or basket making, to convey these lessons and to reinforce them in a variety of different ways. Those are the challenges that we experience. I'll end on the note that, in fact, as David experienced, we have 10,000 active participants in this intervention alone today. We have mirrored the 57% reduction in incident diabetes that they demonstrated in the original efficacy trial. We had 76% retention at the close of the 16-session lifestyle balanced curriculum. And that demonstrates, one, the power of this evidence-based practice, two, the ability to figure out how to make it locally meaningful, and three, as a consequence of that, how to capitalize on the creativity, the commitment, the enthusiasm, and the vision of the local populace. Thanks. They did quilts. They did quilts about their logos at the end, and we now have several blankets, quilts of all of their logos that actually go from one grantee to the next each year to recognize their success.
To be a nice framing of scale, too. I mean, we have some examples at a very clinic level, individual unit clinic level, ranging to community, around to state-based, multi-county, all the way to national planning. So it was great to kind of see differences as well as similarities. I noted in terms of some of the similarities, the importance of how you all use partnerships and engagement throughout the process, and that it's interesting how it all turned out to be a key learning for each of you independently. I think that speaks to the importance. And then the other piece I heard was the eye towards the future. You phrase it in different ways, but the sustainability, the scalability, as an eye towards that in the initial design phase. So we will open it up. Your mics should be on, and we have mics that will run. So we'll open up for questions. We can do about 2 minutes. Yeah.
Thank you all so much. It was a great presentation. I have a question for Dr. Goff. You were referring to the fidelity of the intervention and being careful along the way. There's a new concept now of step wedge. It might not be new, it's new to me, but of the step wedge approach for implementation. How much can we deviate from the original intervention fidelity along each step? I mean, just a discussion. I don't want specific.
So just so maybe everybody knows what a step wedge design is, but it's the idea where you want to eventually give the intervention to everyone, And so you might have a waiting list, and you might have multiple waiting lists. So you might randomize to intervene in this group and not in this group initially, but then they get brought in later as a intervention group, and therefore you have the pre-post in that group as well as there are a comparison for the initial group, and you could have multiple groups and multiple steps and so forth. So yeah, I suppose you could be tempted, based on what you learn or think you're learning about intervention implementation, to tweak the intervention between steps, and that's a very reasonable thing to do. I think that the challenges that come with that have to do with again, making sure that you don't tweak it to the point where you can't disseminate it ultimately. So hopefully that wouldn't happen. And the other is that at the end of it, you're probably going to want to pool the experience of the intervention group. And if the intervention changes so much that you can't pool it, then that would also be, I think, a bit of a challenge. But otherwise, I think within reason, this idea that Spiro mentioned of flexible uniformity is very reasonable. I don't know if others have comments.
Just to tack on to what David was saying, the flexible uniformity came prior to the implementation of the intervention. One of the challenges we faced is that we had to have evidence that this intervention would work, or we weren't going to be in a position with the policymakers and funders to be able to justify it and expand it and institutionalize it. And if you change things along the way, and you come out with less than the anticipated level of desired outcomes, you don't know what's responsible for that. And for us, it would have been the death knell, because we wouldn't have been able to demonstrate what the evidence-based practice initially suggested we should.
Yeah, I would just underline that I think it's important before you launch the experimental model that you determine what are the core elements that can't change and what are the sort of more adaptable elements. And I think sometimes you can do that, and then you can be reasonably comfortable about certain things changing. But I would agree that you want to do that before.
Other questions? Comments? Yes.
Hi, also on the topic of fidelity, I'm wondering about the balance between fidelity and scale, where, like Dr. Goff had mentioned, a train the trainers who train the trainers model, and just kind of preventing drift.
Yeah, so one of the ways that we envisioned a disseminatable approach to trying to maintain fidelity was to have the community health workers meet as a group. And when they met as a group, that group meeting was facilitated by the diabetes educator at the Diabetes Care Center. And so that provided them the opportunity to get together, talk about how things were going, raise issues that were coming up within their groups, and develop strategies as a group to deal with them. Also, there was, as I mentioned, the enduring materials, where we developed DVDs, videos of the content from the DPP curriculum, so that there would be kind of standard information transmissal. We didn't have to have experts. And I like Spiro's comment about, experts. The community health workers didn't have to be diabetes prevention experts, right? They needed to be really people who lived the life of the community and could relate to people who were sharing that same life and the challenges they're facing around diet and physical activity and lifestyle, and be able to bring people together and be good group facilitators. That was really the key there. So, that's the way we tried to focus on making sure the intervention was going reasonably similarly across the groups, and we thought that was disseminatable.
Any others? I'm wondering if maybe Ross or Julie or are there any other things that you would want to add based on your experience when you've been designing at the design phase that could be points to add, or put you on the spot again?
I think that between what we saw in the introductory piece and these examples, I think our one of the big, what you'll hear over and over is stakeholder involvement early and often. And figuring out how to do that, who the stakeholders are, how you keep them engaged when the research products might be 5 or 6 years out, I think is always tricky. So we've frankly gone through a lot of stakeholders and trying to keep them engaged through the years and keep them over and over. I think some of the best, we've got, one of the things we've looked at in some of our designing for dissemination is among researchers, who are the best disseminators, and by far the strongest predictor is someone who has practice experience. And so if you can find researchers on your team who have worked in practice, done an internship in practice, spent time living in that other world, that might be one of the most important variables to keep in mind in this sort of engagement process.
If I could just add to that, Ross, when I think about models of dissemination implementation, I think that we haven't progressed far enough to have more practice-based researchers who are implementers and disseminators. And I think from the various projects I've been on, it's really clear to me that living in that practice setting and understanding it is very, very critical to success of dissemination efforts. The other comment I was going to make about the planning for dissemination is when I think about it, there's one simple question that I often ask for the stakeholders and delivery system leaders, which is, when we get to the end of the project, are you willing to commit to supporting this dissemination effort? And, it's kind of a simple question, but it's a very important one. And also to be asked at everybody who has influence in making that decision.
I had a question for Arnie Beck. After you did the social network mapping and identified the opinion leaders and patterns of advice seeking, can you elaborate a little bit more about how you used that information in your project?
Sure. The social network mapping confirmed some of the things we knew by being in the practice setting and observing and talking to the folks, but it also identified people we didn't know who had some influence that wasn't sort of immediately obvious. And so what we did then is in the planning and early implementation phase at the clinics, made sure that they were involved and sort of collaborators in that process, and they might not have been thought of as collaborators before. But these are individuals who could make or break something. For example, if you have an MA, one of the social network map I showed had an MA who was particularly influential. We wouldn't have intuitively known that necessarily. But we made sure that in the clinic leadership at that practice that we included her in the decision making and planning for this, and also sort of anticipated what the barriers would be. And I think that ends up often being one of the more salient sort of benefits of the social network map, is identifying what could kill it, by looking at people who have influence and influence in a negative way.
Just a couple of follow-up points, and thank you all. These were wonderful case studies there. Just on this issue of designing for dissemination, which I think I love the different ways that you all come to me. I saw this emergent commonality across that. But to me, this goes back to one of the earlier things we talked about today, that's the difference between D&I science and local QI. And again, you all said it in your own way. For me, maybe David kind of hit it on the head the most, about you ask yourself, can others do this? Can these other 3,000 centers do it? Where if you're doing local QI, in some ways you really don't care about that. You just want to produce your best result for this setting right now, today. But if you ask this broader question about that, and there's one other thing we can send along here that I like. It's one of the most systematic approaches to this that I've seen, that Laura Leviton and colleagues of Robert Wood Johnson have developed what they call an evaluability assessment. And there's some tools and questions, but it's exactly those type of questions that each of you ask along there. But I think that's a useful kind of trick of the trade. And then just to build a little bit more on the partnership, Ross's comments and the nice examples that you had of partnerships, and maybe ask the panel to reflect a bit. To me, I also think that's one of the secrets maybe I would add just a point about its ongoing involvement too. I think a lot of people, those of us that are trained traditionally, we kind of get we need to do this, but it's not enough to just hold an initial planning meeting with the stakeholders, and then you come back and see them 5 years later. But how, and I think if you have any thoughts about how to have that be ongoing partnership. And then the other issue that, again, I guess a question, but reflecting Spiro's point about some of this where it really is art, maybe more than a science, about, in my experience, the different stakeholders, almost all of these are complex multi-level interventions where you have different stakeholders. Those stakeholders have different perspectives, and they likely, I'm going to make up, likely don't always agree. And to me, that's one of the things we need to work through. That what do you do, and how do you handle that issue?
Well, I noted in our 14-month planning period, we met with the 3 to 5 grantee staff of each of the 36 grantee programs for 2.5 days, 6 times in a year. We continued that. We met on a quarterly basis thereafter for 2.5 days each of the successive years. It was absolutely critical. And one of the things we anticipated, consistent with the notion of peer-to-peer learning, was that in fact by end of year 2, we turned over the planning of the grantee meetings to the grantees, and we became facilitative and supporters of that. And they knew themselves better than anybody what their technical assistance needs were, what were examples of success that they wanted to share. And again, it was the opportunity to bring to the fore 2 things: their creativity, and secondly, their sense of actually controlling the agenda within certain parameters which they had all agreed and been socialized in the first year. So.
And one comment I'd make about the first point, Russ, is that what you're describing is a little bit antithetical to kind of a traditional academic model, because you end up spending a lot of time in the trenches understanding and developing collaborative relationships, which are critical to make anything like what we're talking about work, and which I think are really interesting, but they also take away from grant writing and other sort of traditional academic activities. So it's a tension that I've been aware of for years.
I just want to comment on one of the problems with our project, despite the fact that, well, first of all, it could have been an entirely top-down approach, because the state public health department has the right to recall kids without any involvement on the part of practitioners, or, So we thought that was a mistake, obviously, and we thought it would be more powerful if we did involve them. But it brings up a problem. Our project brings up a problem because the dissemination seems like it would be a slam dunk, right? It was cost effective, it was more effective, but the partners that weren't involved were maybe the payers. And, who's going to pay for this? Because the public health department, they don't have the budget. Practices don't have the budget. Somebody needs to pay for this. So future iterations of our project are trying to involve payers as well in that, mixed with an upfront, as you said, upfront commitment that they will consider supporting this.
Yeah, just a couple of thoughts. One is, as I said, we were advantaged by having a community advisory board already for the Diabetes Care Center that we work with, so we were able to stay in touch with that group through our relationship with the center. And in fact, the medical director of the center was one of our members of our investigative team. So that was very close. And then we had the next level of stakeholders, our diabetes educators. We interacted with them regularly, and they interacted with the community health workers. So that there was an ongoing kind of partnership reinforcement. And we did lose a community health worker or 2 along the way that, for a variety of reasons, which, of course happens with staff turnover and so forth. The other thing in terms of dissemination and testing this idea that, have you made decisions along the way that harm the ability to disseminate? We don't know for sure yet, but right now the group in North Carolina is working with 5 local health departments to see if this program that we did in one diabetes care center can now be done in 5 local health departments at a distance. So we'll see whether we get some sort of fall off in the intervention as it gets further away from us, and whether certain things that we did they're able to do or not able to do.
So I'm just wondering what you guys are seeing in terms of adoption, just the idea of the importance of dissemination and implementation at the federal level. Obviously, it's something that affects a lot of work, and I think that there is maybe a more natural acceptance of this kind of theory in an academic sense. What I see when we have discussions with our federal contractors is that they don't start with the idea that maybe they should get input on what is actually happening and then make plans. It's like they decide that something is important and move forward with it, and the money is already allocated before the evidence is there, that maybe that's the right way to move forward. And I'm just wondering if you've spoken at all to any of the federal agencies and have a sense of whether or not this is even on their radar.
Are you talking about funding agencies?
Yeah.
Oh, yeah.
Specifically CMS, but I think it's true of a lot of, I think there's a big difference between NIH's approach and CMS's approach.
Yeah, that's a good point. And we're involved in one of the CMMI projects, and actually they do seem to be very supportive of implementation dissemination efforts. It's around 9 sites across the country, and by definition, I think they have to pay attention to that. I also think that we're seeing more of that kind of language and method and just framework come into the RFAs. But that said, last time I checked, maybe it's different now. Late stage translation is like 5% of the NIH budget. So I think there's still quite a ways to go. Correct me if I'm wrong on that. If there's newer data, but so it's still a matter of walking the talk, I think, in some ways.
I think your question really raises an interesting issue for me. I've always, in the 3.5 decades of my career, seen myself as a scientist, but also as a translator and broker for Native communities in terms of bridges to resources. And so I'm before Congress 3 to 4 times a year to the various committees that are relevant to the health initiatives that I'm involved with Native communities. So I see it as bookending the process. And by educating staff and congressional representatives, current circumstances suggesting otherwise is that as a possibility, you get the pressure down from the funders and policymakers, and then with the advocacy groups from your constituents moving up, it tends to make the educational process quicker and more effective with the agencies in between who fund these kinds of things, in my experience. But you know what? Did you ever have a graduate course in advocacy or translation around research findings and its application in the real world and these kinds of things? And I think that's a really missing part of our training and preparation as scientists if we're going to move into D&I.
I think Sparrow makes a good point about the advocacy groups, too. There's this kind of bottom-up pressure on some really key sort of public health issues that manifest in RFAs that if they align with your work, it's really more likely that you're able to use D&I concepts in those kinds of things.
Yeah, and I would say D&I is more on the radar now at NIH than it was 10 years ago for sure. Witness the study section that Ross is now chair of, and I chaired for a couple of years before him. It's also on the radar at CDC, although they think of it more in terms of community-based rather than health system-based. And ARC, of course, has this concept, as does PCORI. So I think there's more and more adoption of this approach. The other thing I would say about advocacy training is that I think the best advocacy training I've had in my professional career was through the American Heart Association, shameless plug. So if you want to develop your ability to be an advocate, you could do a whole lot worse than deciding you want to volunteer for a really top-notch organization like the American Heart Association and get some advocacy training and get involved at the state and federal level to advocate for something important like cardiovascular health. Shameless plug.
We have time for one more question before lunch.
This is a little bit of a follow-up on the prior question, but what struck me about these projects is that they are long-term investments in a particular intervention with particular population or set of stakeholders. And following up on the kind of funding issues, I have had funding through ARC. You're talking about a 3 or 4 year funding cycle, not a huge amount of money. And how did you clearly these types of things that and like CMS, they want things that are, the shovel-ready idea. We're just going to put it out there. There's not really a lot of interest in planning phases, from what I see, to fit a dissemination project at multiple sites into a 3-year window on a limited budget seems to me to be, counter to the whole way that this works. It doesn't fit into the classic structures.
Yeah, I'd like to comment quickly on that because the CMMI project I'm involved in is actually, it's one of those 3-year projects, and because across online sites enrollment has been slow. This is for patients with poorly controlled diabetes or heart disease and depression and care management, behavioral health interventions. I'm having to actually go to our stakeholders and leaders in our organization to start to put together the elements of a business case. That's how everybody likes it in our system, for sustainability of this model and whose budget it fits into. And so I'm having to do that like a year before I even thought. But I think you're raising a really important point that well before the end of these relatively shorter term projects, we need to be talking to other stakeholders around funding for sustaining programs and be able to do whatever we can to show evidence for the business case for it.
Yeah, I would just add to that like everything else in life, you need to beg, borrow, and steal everybody else's infrastructure. So, you should try to find out what practice-based research networks are in your area, including public health practice-based research networks. There's a public health practice-based research network here. There's a practice-based research network here. There's multiple of them around the country. And so you need to, if you're just getting started, you need to find somebody who will take you on and let you beg, borrow, and steal their infrastructure, because then it makes it more practical to be able to do this. If you're starting de novo with no track record, no experience, no infrastructure, you can't expect to be able to do the sort of project that you're talking about in a 3-year period. But if you're working with someone who's kind of been there, done that, and has some infrastructure you can borrow, you may be able to get that done.
Okay. Well, thank you very much. This has been